So that being said, thank you for joining us. And I am Alex Beineman. For those of you who've maybe never been with us before, I'm the Director of Program and Staff Development for Camber Children's Mental Health. And then I'm joined today by Sarah Behrens, and I will let her introduce herself.
Good afternoon, everybody. My name is Sarah Behrens. As Alex said, I'm an LSCSW, and I am the Executive Director at Camber, Kansas City's location. Welcome, everybody, and excited for you all to go on this journey with us.
Awesome. Thanks, Sarah. So our objectives for the training today, if you were with us last week, we really went over the diagnostic and assessment process for post-traumatic stress disorder in youth. And so today we're really going to be looking at best practices in PTSD treatment for youth, looking at effectively treatment planning through culturally competent lenses and conceptualizing care through a case study example that Sarah will share with us that is the reflection of a client or maybe a couple clients. I think we've kind of melded some together just for HIPAA and privacy reasons, but who did join us at one of our programs in the state of Kansas. And we're going to walk through her PTSD treatment. So just to get us started off, a little bit of a review from last week for anyone who maybe was unable to join or sorry about that, or who didn't maybe need just a little review. I know that sometimes time moves really quickly and here we are kind of all like, that feels like a year ago. So there are some pretty interesting statistics across the top of the screen here. We know that 70% of people in the global population report experiencing one trauma. We also know that that number is probably low because a lot of people are not going to be comfortable self-disclosing that or maybe aren't being asked or things like that. We know that when looking at numbers like this, there's going to be some of those discrepancies. Second, we have that 14% to 43% of youth experience at least one trauma. And then in turn, 3 to 15% of girls and 1 to 6% of boys are going to develop PTSD. When we're looking at the LGBTQIA community, those numbers are significantly inflated. I will say that this does also include adults. We don't have child-specific data accessible right now, but you're looking at about 48% of LGBT individuals and 42% of gender diverse individuals. And then lastly, that kind of helps get us into some of our cultural factors conversation is that 50 to 60% of racial minority individuals report having at least one experience with personal discrimination. So that's not including systemic discrimination or discrimination through like policies and things like that, or just like I don't know, institutional cultures. This is something that's like personally directed at them. And then we walked through assessments, brain science, and important cultural factors. And so when we talked about assessments, we really talked about the fact that there's like over 1,400 different assessments that can be used for PTSD. And that while all of them are effective in some way or another, it's really utilizing that cultural lens, being able to identify idioms of distress, understand, explore explanatory models of illness, and really understand like where people are coming from and what their experience is, that really makes that assessment robust or really ensures that we're doing an adequate assessment. And then we also got into some of the brain science behind what happens when someone has PTSD, what happens to a child's brain when they are exposed to kind of the level of trauma that would cause PTSD. And what we saw with that was an enlarged amygdala, which obviously is going to lead to more like fight or flight, struggle with impulse control, struggle kind of regulating safety. We saw enlarged ventricles, which leads to increased cerebral spinal fluid in the brain, and that can lead to flashbacks. And we saw overall just a smaller brain development. We don't know if that is due to like shrinkage post-trauma or a smaller brain growth time frame. That science we don't know quite yet, but we know that the brains are overall smaller of children who have been exposed to and experienced significant trauma. And then again, with those important cultural factors, we really just went through understanding that the way that the diagnostic criteria is written for this disorder really is kind of exclusive of racial discrimination or minority stress. And we really maybe need to look at some different ways to conceptualize that criterion A trauma through that cultural lens to really get where we need to go with clients. And we're going to talk more about that cultural impact and those cultural factors as we go through our treatment planning today. So we kind of wanted to start here with interventions and levels of care. And Sarah, chime in. I know that you work in more intensive levels, and that's what our programs here at Camber are. But there's really kind of 3 levels or 3 environments in which care for any mental illness, but PTSD specifically to the point of this training can be offered. And that's in the home. So there are things that caregivers can be doing at home to build resilience in children, to role play and exemplify healthy relationship skills, which is a huge protective factor for kids who've experienced trauma and are diagnosed with PTSD. And they can also provide that psychological first aid, that immediate processing, that validation, those things that are going to help either prevent trauma from developing into PTSD, or really just make sure that that space is comfortable and safe and a place where a child can process what they need to process while going through PTSD treatment. The second kind of level or area of intervention is in our communities and schools. And this is your community mental health centers, your school counselors, your outpatient therapy programs. This involves medication management in contact with a psychiatrist. This can be like community group therapy. This can be peer-led things. So this is kind of where we see more of that professional intervention, but we're still in the community. We're still very least restrictive. And that is kind of, what I think most children in the US when they're receiving mental health treatment receive. And we're always trying to evaluate for the least restrictive level of care. We don't want to restrict a child any more than is absolutely necessary for safety. And then if we are having some of those larger safety concerns, we have intensive and inpatient treatment. So that is intensive outpatient programs that run for multiple hours a day that are very hands-on, that are very integrated with your child. And then there's therapeutic day treatments, which are similar to that. And then you have and residential PRTF. And that's really what Camber specializes in. We have 5 programs across the state of Kansas, 3 acute hospitals and 2 PRTFs. And then we are currently opening a new acute hospital here in Olathe. So I'm actually here in Olathe, and it's just on the other side of the building that I'm in right now. It's being built and it's in partnership with Children's Mercy. It will serve both children and adults. So that is kind of another acute option that's going to be here in the Kansas City area. Sarah, do you kind of want to talk about what some of the different severity of symptoms that's going to lead to some of these? I just a brief kind of overview of how you might know what you need when, or what a child needs when.
Yeah, absolutely. And so, essentially Alex did a great job of kind of explaining those levels of care. And really when the need for an increased level of care is how you determine the severity of the impairment across those 3 different areas, whether it's home, community, and school. So a lot of times the folks that we see reaching out for our services is because their child or their client is impaired, maybe at school where they're having behavioral dysregulations that include creating environments that are unsafe for the other students in the classroom. Maybe they're struggling to manage their emotional triggers as well, tied to some of those PTSD, but to other things as well. And so that is making an unsafe environment for them at the community or at home or even at school. And so that is when we will typically see increased engagement in the need for a level of care that may end up being acute or residential. And so the way we get those referrals a lot of times are because clients are being seen at emergency departments. And they're doing those assessments of, can you safety plan? Can you keep yourself safe? Are you at harm to others of a risk that you might, engage in some of those behaviors as well? And so from there, that's when they call our admissions team and we'll let them know that they need an acute stay because maybe it's something that is a imminent danger or something that had just created an incident. As far as residential, then that may be an indicator of a need when you've had several different acute hospital stays or the different community services that you're engaged in are just not meeting the need of where you're at currently. And so then you will go through the process of being on wait lists and also requesting residential, which is just a longer term. So our acute stay is typically about 5 to 7 days. And then the residential is typically about 90 to 100 days where we do more intensive and more services to really treat that longer term.
And a child diagnosed with PTSD could very well never need that intensive treatment, or they could really kind of fluctuate through all different treatment levels. So it really is just based on the need of the child and the safety concerns at that time and the functioning level. All right, so we're going to go into just a few of the common psychotherapy treatment modalities that are used to treat PTSD on all different levels of care. So some of them include trauma-focused CBT or trauma-focused cognitive behavioral therapy, CPT, which is cognitive processing therapy, play therapy, your exposure-based therapies, expressive therapies,
EMDR, and then narrative exposure therapy and medication. So just to give you kind of a brief overview, you really want to have an evidence-based model to utilize with any sort of diagnoses, but especially PTSD. So just to kind of give you a quick overview of some of these, according to the American Psychological Association and the National Center for PTSD, there are therapeutic modalities that are more highly recommended than others. And so that is what we're presenting here. Trauma-focused CBT is really focused on that cognitive behavioral therapy. This is the modality that we will be utilizing in the case study, as well as some other ones. But this is sort of the main therapeutic practice that was used in the therapy sessions. It generally includes the client directly discussing the traumatic event and having some exposure to that. Anxiety medication, or excuse me, anxiety management through techniques, relaxation, coping skills, having some assertiveness training as well, correction of inaccurate or distorted trauma related thoughts. So those cognitive distortions. We'll get into more detail in the case study though about how that plays out and give you kind of paint the picture or give you a visualization of that. The CBT part of trauma-focused CBT is often focused on challenging cognitions. So making sure, that you're coming from a place where you feel like your world is totally unsafe to learning those techniques to create safety. And it's really about creating a system of care around the client, whether that is an internal system of care, but also utilizing the support system around them. We're really focusing on the relationships among the thoughts, the feelings, the behaviors. We're targeting those current problems and symptoms and focusing on challenging patterns of behaviors. We really want to challenge those thoughts and feelings that lead up to those difficulties in functioning. It really is about analyzing sort of what got you into this and how do we go from there, or what's my current impairment, and then the future focus piece of it as well. There's a lot of focus on psychoeducation, and especially when you're working with children, it's key to ensure that your caregiver, your support team really knows the effects of PTSD and the treatment plan. Research shows us the better the caregivers cope with the trauma and the more they support their children, the better their children will function. So therefore, it's really important for caregivers to seek treatment for themselves in order to develop the necessary coping skills to help with their children, and also practice those as well, because if you're not practicing those coping skills, they don't come natural, and that is really key. Some of the elements of the cognitive processing theory really is a specific type of cognitive behavioral therapy that helps patients learn to modify, challenge, and all of those unhelpful beliefs or those distortions, just really related to that trauma. So it's kind of honing in a different way to really focus on certain elements of that. So while CBT really focuses on the thoughts, behaviors and feelings, CPT is really focused on the negative beliefs. And some of this will tie into some of the principles of EMDR as well. Play therapy can be used to treat really young children with PTSD. Maybe they're not able to truly explore or process the trauma more directly. And so play therapy is a great option for them to engage the creative side of their selves and their brains to help process through some of those negative beliefs, some of those traumatic events that happened to them. And then, of course, a more controversial approach is the exposure-based therapies. They can be somewhat controversial when you're talking about children, especially because these events can be really scary to them. So exposure-based treatments seem to be the most relevant when memories or reminders of your trauma is so distressful, it can bring extra distress to the child. So you really have to assess whether that's the right approach for that individual or the client. It also really comes down to their ability to contain outside of the session, and if they're able to do that and be able to sort of contain after the session and move on from that. So there are some different elements that you have to be aware of when deciding to utilize this approach. Another piece of the exposure-based therapies are imaginal exposures, so repeated recounting of the trauma memory to process those emotions, gain some context and some control over the memory. When selecting events to be recalled in the work, it's very important for the clinician to access the context and the function of the client's cognitive, emotional, and behavioral responding. In vivo exposure involves engaging with trauma reminders, and i.e. their triggers, and emotions by doing activities that the client has been avoiding since the trauma. The goal is really to facilitate the habituation of learning new and improving learning new concepts and also improving functioning overall. And then, of course, we have expressive therapies. And so this is something that we will also talk about in the case study because we do utilize a multi-modality approach to treatment, especially at Camber. And so do a lot of other folks when treating PTSD. So these interventions are typically art, music, dance, writing, recreational. The goal is really to create and support a mind-body connection. Really, writing can be a very powerful expressive therapy to use in this because you are going to be creating a trauma narrative. Some of the four main components of expressive therapy include expression, imagination, active participation, and mind-body connection. So really building those skills and utilizing the client's strengths within those therapy modalities are going to be really key in your decision-making process of which approach to take and when. Conditionally recommended. So interventions that receive a conditionally recommendation all have evidence that indicates that they can be a really great treatment option and have some outcomes. However, the evidence may not be as strong, or the balance of treatment beliefs and the possible harms may be less favorable, or the intervention may be less applicable across treatment settings or subgroups or individuals with PTSD. So some of those are EMDR, so eye movement desensitization and reprocessing. This is a structured therapy that encourages the patient to briefly focus on the trauma memory while it's simultaneously experiencing the bilateral stimulation. So typically it's eye movements. With kids, it also typically is less tolerated for eye movements so that you use other modes, whether it is utilizing pool noodles to tap on their knees or having them tap on their knees as well. It also is something that you can also use sounds, and they also have devices that you can put in your hands that also give like little beats of to kind of, create that stimulation in your hands as well. So while EMDR has been effective in treating adults, research with children is not as strong. Studies indicate that it is a cognitive component rather than the eye movements that account for that change. So there are elements that you can utilize as into some of these other modalities for that bilateral stimulation, but it is not completing the EMDR process. Another special consideration for EMDR, especially with clients who have complex traumas, this modality is typically at least a year that you want to be able to focus on this. Next is narrative exposure therapy. This helps individuals establish a coherent life narrative in which they are able to contextualize traumatic experiences. Can also be used in a group setting, though, in treatment as well. And then lastly, medications, of course, which we will go into more detail on the next slide with Alex, but medications are always something that should be assessed for a hand-in-hand approach and not a catch-all.
Thanks, Sarah. Yeah, so as she said, we can talk a little bit more about medications, and I want to kind of preempt this slide with I'm not a psychiatrist nor Sarah. And so what I am sharing here is directly from the National Center for PTSD website. This is very generic information, and I highly encourage any provider or practitioner that is working with kids with PTSD to seek some additional knowledge around medication with PTSD. I'm not the one that should be providing that. It's not my expertise, but I did want to give some base information. So there are 3 medications currently recommended for PTSD treatment in youth. They are SSRIs and SNRIs. There's 2 SSRIs and 1 SNRI. They are typically antidepressants that can help with some symptom reduction. And it's pretty much just because kids with PTSD have different levels of chemicals in their brains, and these medications can help regulate those chemicals. The 3 main recommended antidepressants are listed on the screen, and their non-generic names or name brand names are Zoloft, Paxil, and Effexor. We've all heard that I'm not going to pronounce the generic names because I know that I won't get them correctly. But these are kind of that like baseline, and they do have some side effects: upset stomach, sweating, headache, dizziness, etc. But again, those are all things that should be discussed with a psychiatrist. And to Sarah's point, where does medication fit into that? And I think that the way that we look at medication is, what is the level of functioning and how impaired is it? One, is this child unable to engage in active treatment because of some of these symptoms? Can we use medication to reduce symptoms enough so that a child is able to actively engage in treatment, or kind of manage in some of the day-to-day expectations? But again, it's not recommended for PTSD that medication would be the sole treatment or would even be the main focus of treatment. It's definitely something that we look at as a supplement to really ensure that we're able to do the in-depth treatment that is going to really kind of help rebuild those cognitions and address the root cause issue.
And Alex, it's important to note too that, you always want to do that medical rule out before you consider any sort of treatment, because that is so important, and that does affect the holistic care that you're trying to provide to our clients.
Absolutely. And we talked a little bit about that last week with some of the different things you have to look for when diagnosing and some of those medical rollouts. So Sarah did a really wonderful job walking us through all of those like psychotherapy interventions, but there's other interventions that are really beneficial for kids with PTSD, or really just kids who've experienced trauma. I would imagine that most people here today have heard of trauma-informed care and understand a bit about it. So we're not going to do a super deep dive into it today, but I did want to make sure that it was mentioned. It would be remiss of me to do a presentation on a trauma disorder and not discuss trauma-informed care. So the idea behind trauma-informed care, at the very simplest, or the way that I think it's most easily understood, is the idea that we're shifting from the concept of what's wrong with you, why would you have that behavior, to what happened to you, to understanding that children who have experienced trauma, especially children who've experienced trauma to the extent of developing PTSD, have different brains than we have, or have different brains than children who have not experienced that trauma. And that directly impacts their behavior and the symptoms that we see. And so until we can really remove that blame on the child for the behavior and really understand that it's out of their control, and that our job as providers is to help them gain control over that back via, rebuild like neuroplasticity and rebuilding the brain and changing the wavelengths of the brain and all of those things, we also have to understand the capacity to cope. We know that children who've experienced trauma, and especially children with PTSD, have a very limited capacity to cope. And the best way for me to kind of explain this is the visual of, you have a pint glass and then you have like a shot glass. And I, as someone who has not experienced an exorbitant amount of trauma and does not suffer from PTSD, have a pint glass worth of capacity to cope every day, meaning that I have 16 ounces, I think that's how much is in a pint, of stress that I can take before I overflow, before I explode, before I'm struggling, before those kind of like more explosive symptoms are coming out. And when we're looking at a child who's experienced trauma or has PTSD, they have that shot glass sized capacity to cope. So that 1.5 ounces, meaning that something that to anybody else might be like, really? Like that's that big of a deal, could really be that big of a deal to them. And that's how it's going to feel. That's how they're going to experience it, because that capacity to cope is so much smaller. There are 4 R's to trauma-informed care, and they really just are kind of systematic. We want to realize the prevalence of trauma, the fact that most people experience trauma. We want to recognize the effects of it and the symptoms of it and be able to identify that. We want to respond by integrating trauma-informed care and trauma-informed approaches into all of our settings, making sure that we're understanding what that looks like, we're being respectful, we're resisting power and control. And we'll talk a little bit more about that on the next slide. And then we want to resist re-traumatization. We don't want to fall into any of those traumatizing patterns or any of those behaviors that are going to kind of cause that trigger. For sure, anyone who's ever worked with a traumatized kid knows that you're probably going to trigger a child really unintentionally at some point. And so when that happens, the trauma-informed care approach is really in that like repair stage. So how are we communicating about it? How are we repairing that relationship? How are we having the healthy accountability as the adult or the provider in the situation, ensuring that the child understands that we know that it's not, a chosen behavior, that it's something they're struggling with, and that maybe we misreacted. So kind of on the same topic, this is just over here on the right side of the screen. These are...
Really
Yeah.
quick, before you go into this slide, I think there were a couple of questions
Yeah.
in the chat. So I don't know
So
if Sarah wants to chime in.
Yeah, I can go ahead and throw that out there. So I was able to answer one, but there is a question here that says, how often do you see negative effects of SSRI in kids, increasing hyperarousal, similar to how it can trigger a manic episode?
I don't know that I feel comfortable answering that question just because I do not have a strong knowledge of medication. Sarah, you're a little more like a little bit closer with the treatment that we provide in that concept. I don't know if you have an answer, if that's something that we might want to follow up with one of our doctors about, and we can always email out an answer.
Yeah, I mean, I think it definitely will change sort of based on sort of your knowledge background, right? Like as a clinician, my idea of how I notice those or observe those or communicate those, it may be a little different than obviously the doctor. However, what I will say is that us, specifically to Camber, we take a multidisciplinary approach. So we are getting together to collaborate, talking about those things that we're observing, whether it is those somatic, situations where they're experiencing some different physical, whether that is just physical reactions to the medication or just in general, because some of those might be the psychological effects as well. And so I would say that we utilize our treatment teams as a multidisciplinary meeting where we do assess and kind of talk to those as a greater group. And so it's very key to have those observations from some of those general direct staff and or your caregivers. A lot of community, mental health centers also use the wraparound approach too. So I would just say having all of those folks in the room that get to see the clients on different levels, whether it's community, home, school, and those types of things, to observe and share those, those things they observe. Also listening to the client because they ultimately know themselves better than anybody and might be able to really hone in on what specific symptoms they're experiencing as well. So a short answer is really taking that collaborative approach to ensure that across different disciplines we all know sort of what the client's experiencing. But I would say that is going to be different based on the lens that you're looking through, whether you're a clinician, a caregiver, or the psychiatrist, or even the medical provider, because a lot of times our clients are utilizing their primary care physicians for symptoms of, stomach aches, headaches, those types of things that may be tied to some medications and or the traumas themselves.
Yeah. And so I don't know that we necessarily have like a frequency number for you, but that is a really great example of like how we can kind of get that information and really make sure that we're keeping a really close eye out for that. And I think Sarah let me know that was our last question. So I'll hop right back in here. So back onto the trauma-informed care concepts. So again, on the right side over here, we have some much more traditional values or things that we see kind of in more traditional environments. And then the left side over here is going to be more of those trauma-informed practices. And so you have like a tradition of toughness are valued as the best care approach, or like, I need to prepare these kids for the real world. I need to like let them know that these like punitive consequences exist in the real world by making them experience them now, versus a recognition of culture and practices that are, sorry, that should say aren't re-traumatizing. I apologize for that typo. So we're looking at things that are not based in that culture of toughness, that are not making kind of that same effect happen over and over again. We want to kind of lean away from like compliance and power and control and like rule enforcers. Now that doesn't mean that authority doesn't have a place, but we want to kind of seek that authority through healthy accountability, through models of respect, and through kind of like a give and get collaborative relationship. So we want our caregivers and supportives to like pay attention to that collaboration culture. And if at any point we aren't being collaborative with the client, we aren't being collaborative with the client's family or something like that, then we're really not creating a trauma-informed environment. We want to see behaviors not seen as like provocative or volitional and seen more as like, that's a communication. Every behavior happens for a reason. We want to see less manipulative, needy, attention-seeking type words in our language and much more objective, neutral language about like just the base behavior that we're seeing. Again, all of these things are pretty elementary when it comes to trauma-informed care, but I also know that while we can have these understandings and these beliefs and truly embody a trauma-informed approach, as our stress level as providers goes up, our ability to do all of this decreases. And so our ability to stay regulated, to stay focused, to stay in the moment and make sure that we're putting that trauma-informed approach at the center of the care that we're providing is imperative to ensuring that the environment is consistently trauma-informed. And so that's, I think, where it can be a challenge. I know a lot of people work in a lot of different environments where maybe you are the mental health representative in that space. And so trauma-informed care is not fully understood by everyone in your organization or everyone in your practice setting or environment. And so how can we kind of give some of those concrete ideas of how we can adjust the culture to be more trauma-informed? I know that that's something that I hear a lot. Sarah, I see you've unmuted. Do you have a question?
Yep. Very great. Yep. I have another question here. Are there any good models or pre-made education materials for caregivers to shift away from the rule enforcement, tough love care? I find that shift is so very hard for the Midwestern culture I provide care in.
Yeah, that's a great question. So the model that I'm going to recommend is one that we use in all of our care centers. And I know that it's used in schools like nationwide and different things, but it's called PBIS, or if you're a parent using it, they'll probably refer to it as PBS, but that's called positive behavior supports. And it's a model that really operationalizes positive reinforcement and pre-teaching and understanding the levels of intervention your child may need in any setting, at home, in an acute hospital, in a school, and kind of understanding how we can provide the right level of intervention at the right time in a way that's completely trauma-informed. PBIS is really focused in consequences, but not punishment. And so consequences are natural. They can be positive, they can be negative. And so, for example, if you spit on the floor, a natural consequence of that is you may need to clean it up, but that really helps kind of deter the like punitive timeout, do this, do that, or kind of that like beration or that blaming of that behavior, and helps, still meet the need of this needs to be cleaned up. This isn't a behavior that we're wanting to see repeated, with that natural consequence piece. And then again, it's that super focus on positive reinforcement for the behaviors that we do want to see. And that's a very kind of basic overview of it, but there is an organization in the state of Kansas called KIPHIC, and you can use KIPHIC, and their website is a really great place to start if you're looking for some tangible resources about that program model.
It's also really important to note that it's really talking about what's the function of the behavior instead of focusing on the behavior itself. And so what is this trying to tell us? So as Alex, spoke with the labeling language of manipulation, attention seeking, those things, it's really about, reframing of attention seeking can also be connection seeking. And so what can I do to create that connection and provide that support that is really being asked for when the behavior is showing us some negative ways to cope. And so really having that, the other beauty of it is that shared language aspect. If I'm utilizing the same language as the clinician and I'm teaching the caregiver to use that same language, then in, also utilizing that in the school. So if your client or your child has an IEP, making sure that shared language is in there, because then it creates that foundation for your child, your client, to really build those skills, as well as helps reinforce that we're really looking at it from a trauma-informed lens as opposed to the punitive.
Yeah. Sarah?
Yeah, just another question here. What are your thoughts on regressive therapy for a 15-year-old who has experienced severe abuse over 3 years prior to 11-year-old? I think it all says, I'm trying to make sure I understand the second part of the question. And if it gets to be traumatizing all over again, are there studies to show how effective it is to continue that type of therapy?
So I am not super familiar with that modality. However, I will say part of the elements of trauma-focused CBT is about, instead of waiting to expose to the trauma, it's about making sure you have an environment where you're kind of working through exposure of the trauma. And I think that would be important as you're, if your client's regressing in some of those or utilizing different modalities, because I think that is something as a clinician that, we want to make sure they have the foundation of being able to regulate their emotions and behaviors before we sort of bring them into some of those traumas. So I think it's really about building some of those foundations. Can you contain after, some of that exposure? I really kind of define it as sort of a treasure chest, and your traumas are all on side. And so getting the client supported in a way that they can take out pieces of the treasure box and sort of examine them, but also then put them away and be able to contain it. That is also an element of EMDR as well. So I think it really, as you're sort of working through which is the best approach or modality to utilize, I think it really is about knowing your client and their ability to utilize emotional and behavioral regulation skills, but then also contain after exploring some of those things. I'm also a big proponent of inner child work. And so I think that's very important to explore as well, especially because typically our traumas are happening to us, when we're very young, and especially when you get into like complex trauma. So I think it is, important to sort of know where your client's at and start there, but then also utilize some of those safety elements and make sure that you can safely manage through some of that processing as well.
Yeah, I mean, we don't have, I can't definitively speak to studies that kind of say that that's something you should continue one way or another. I don't know that Sarah can either at this time, but I also think like looking at the age of that client, that if that is the experience and where you are, like really incorporating how the child feels about potentially continuing that, or where kind of like their safety is, to Sarah's point, making sure that we have the reinforcement there to process that trauma in a safe way. I love the treasure chest analogy, Sarah. I'm going to use that in many other discussions. I thought that was a phenomenal way to conceptualize that, but really involve them in like, understanding like, hey, there are other things that we can do. Are you comfortable with this? What do you feel like you need? Because I think that when you're talking about an adolescent, the more centered we can put them is in their treatment planning, hopefully the more effective it's going to be. They're going to be more bought in. They're going to feel more supported. It's going to hopefully be a better experience overall. Sarah?
Can you please just repeat the resource again, related to KIPIC, the website and such?
Yeah, it is, the model is PBS or PBIS, and the website is kipic.org, KIPHIC.org. And they also have some different parental resources as well.
Thanks so much. I went ahead and put that in the Q&A, put that website on there.
Thank you. Okay, mosey along here. Okay, so those are kind of the environmental things that really kind of based off the question we were just talking about, help create that environment where we can do the work. We can't do the work if we're not in a safe environment. And so that really helps make sure that that's the environment that we have, that, and the goal being trauma-informed communities, so that children are not only in those spaces in their clinician's office or in their school. That is how we as a community approach one another. The basic understanding that everyone has experienced trauma and that we have to factor that into how we relate to one another. And so part of the environment that we live in and all of that goes into cultural factors of treatment. And so we talked last week, we have the same slide was up about the flow for cultural formulation, interview domains for cultural assessment. And I wanted to pop it back up here because really what we're talking about today in the treatment realm is going to be focused on kind of the back half of this interview. And it really just, again, gets to like really understanding the experience. We talked a lot about how Western psychiatry and psychology is rooted in, the Western experience, the white male experience, that kind of concept last week. But we also talked about how another reason that we see some of these large generalizations is because we're talking about like the DSM, we're talking about a book that needs to be able to be widely applied. But when we generalize to all of these people or to all of these, you generalize human experience, we miss out on really locally relevant things. And so we are going to kind of talk about some similar topics to last week, but how it pertains to treatment planning and how you can ensure that in your treatment planning, you're being fully culturally competent, you're having that lens, and then some of the different things that the research is suggesting right now. So one of the biggest things that research is suggesting that I was able to find is this integration of trauma-focused cognitive behavioral therapy and racial socialization, or specifically, it has a much longer name and I want to say it perfectly, but the racial encounter coping appraisal and socialization theory. And so the World Health Organization defines mental health as a state of wellness in which every individual realizes his or her own potential, can cope with the normal stress of life, can work productively and fruitfully, and is able to make a contribution to society. Mental wellness includes understanding what it means to flourish within environments that may contribute to traumatic experiences and working with adolescents to overcome those adverse experiences. So that environment for minority youth is going to include some sort of like ongoing stressor of discrimination or lack of access or like racial profiling or things like that. And so we have to make sure if we're really truly treating mental wellness, if we're treating mental health to achieve mental wellness, that we're providing all youth, minority or not, with the skills needed to function. So the racial encounter coping appraisal and socialization theory can be integrated with TFCBT through kind of like all of the different principles of TFCBT, and to kind of define what I'm going to call it RS, racial socialization, for the rest of these next couple slides, because it is a mouthful. To kind of understand what that is it's essentially like the transmission of culture, attitudes, and values to help youth overcome stressors related to discrimination of some kind. And so what we've seen in the research is that racial socialization can be associated with positive psychosocial outcomes, improved self-esteem, resilience, lower rates of depression and perceived stress, stronger racial identities, reduced behavioral problems, and overall just a better use of coping skills during experiences of like stress in life in day-to-day life. And some of the different messages that are kind of shared through racial socialization revolve around racial pride, such as like talking about cultural heritage and maybe some of the like successful people of that heritage, looking at barriers. So messages to children about discrimination and racism, and like really highlighting the complexities of managing social interactions with those kind of being in the forefront of your human experience. It also goes into looking at equality and achievement. So it's kind of messages that are uplifting and empowering and informative, and also very racially based in the experience of what those are. And so when we're looking at kind of basically the proposition is that if you take TFCBT and you combine it with racial socialization, you just build it out a little bit more, that we can see behavioral changes that are longer lasting, more impactful, and overall like more holistic care for this population of clients. And so in the next two slides, I have practice, which is like the acronym for the components of trauma-informed cognitive behavioral therapy. So you'll see like PRAC, and then the next slide will go through the next four over here. And then this first column really goes through just like the goals of trauma-informed cognitive behavioral therapy. And then the last column is going to discuss like what we can add or how we should adapt that portion through racial socialization theory to be more culturally competent, to be more robust. And so for psychoeducation and parenting, one of the things that I'm not going to go through like the current trauma-informed care like section of that, but I will go through what we should be adding. And so this would say adding into psychoeducation and parenting is to inquire about those mental health beliefs that are like culturally rooted, talk about prior experience, talk about access to care, issues with access to care, et cetera, and then really introduce this like racial socialization concept as a protective factor for both the family and the youth in treatment. When you're going into like the relaxation component, we want to look and assess beliefs and how the child and family relax and cope with stress naturally at home. And this could look really different. So when we're looking at assessing beliefs, it could be that innate belief that maybe a minority youth has to work harder because you have to overcome some additional barriers systemically. It could be that maybe prayers and spirituality is a huge part of whatever culture the racial minority youth identifies with. And so we want to make sure that we're understanding that that's a way that they cope with stress. When we're talking about affective expression and modulation, we're wanting to identify feelings associated with historical experiences of racial discrimination and provide ways to acknowledge racial stressors based on effective change. So one of the biggest criticisms of trauma-focused CBT or CBT in racial minority youth is that, or in minority, we're going to talk about LGBTQIA kiddos here in a minute, and it also applies to them, but is that when some of the cognitive distortions that we can end up trying to like reprogram or kind of reorder are innate to the experience of discrimination. And we can do a lot of harm if we don't acknowledge that. And so that is kind of where this this principle addresses. So we really want to make sure that, if the feeling is I am unsafe because I am a Black youth in America, we don't want to just outright challenge that as a clinician and to try to completely redo that whole thought, because that's not true. There are different safety issues because of that. Unfortunately, there shouldn't be, but there are. And so we want to find ways to like validate that experience and not kind of like oversee it and essentially tell children that they're wrong when that's the experience they're having. And that's mostly what this affective expression and modulation is discussing. We want to look at ways that the affect changes with the child when they're experiencing that racial discrimination, and then use that to kind of help identify how stressful that situation really was. We don't want to just kind of decide as the clinician, oh, that shouldn't have been stressful, or that wasn't, impactful. When it comes to cognitive coping, we want to really teach and role play techniques that teach children how to behave in certain situations. So that's going to be everything from like what to do when you get pulled over, how to handle maybe a situation where you're being discriminated against. We want to role play these techniques. We want to really understand that this is the experience of a group of people, whatever that experience is, and make sure that we incorporate that into treatment. So we're not just looking at that cognitive triangle and the associations between all of those things, but we're also role playing through like, how do we get through some of these things that are issues, that are struggles, that are traumatizing, that could be a potential trigger. For trauma narration and processing, we want to assess the child and caregiver's understanding of cultural norms around trauma narratives. So do they have any attitudinal barriers to this? Do they have maybe some different mental health understandings that could be, I guess, like that idiom kind of? So they're not necessarily idioms of distress, but maybe they're different ways that they describe things. So this would be things like, we don't like our business. Some of the examples given in this research article are like not telling family business to anybody, or having our business out in the street. We want to make sure that we're understanding the culturally relevant ways they communicate about mental health, whatever culture that is, and make sure that we include that in our treatment process, and that we include that language in our treatment process. The in vivo exposure, which I know Sarah gave a kind of in-depth overview on, is part of this as well. And we want to make sure that we're, again, allowing clients the opportunity to practice skills that will reduce negative cognitions, emotions, and behaviors in response to future triggering racial encounters. So that is a whole category that needs to be covered. This is an ongoing stress you're experiencing, even if it's not what caused your PTSD, even if it's not that single event. It is an ongoing stressor that you experience, and that is going to make it more difficult to cope with this single event stressor and with your PTSD symptoms. So we need to make sure that we're equipping our youth with everything they need to be able to sustain those triggering situations. And that obviously applies to other discriminations as well. Conjoint sessions. So when we're doing like caregiver child sessions, we want to discuss the RS activities that have been shared and really talk about how that contributes to the child's racial identity and to their identity as, just a youth in America, and like through their treatment and all of that. And then lastly, for enhancing safety, we want to make sure that we include a safety plan that equips the youth with how to respond in the event of future experiences. Again, we know that this is something, unfortunately, that they're going to experience again. So what tools can we give them to successfully navigate those situations? So identifying warning signs of danger, role-playing new skills, and ideally, we really want those caregivers involved for this to be successful. Hey, Sarah, what's the question?
Yeah, thanks. This is from Alexis. She asked, what is the best technique to approach a student that has a fawning response to their trauma, perpetrator, and re-experiencing events? Someone who may see treatment or support as the threat rather than the experience.
Yeah. Sarah, do you want to go for it, or do you want me?
Well, I think it's, a couple of different factors. So Alex, I'll let you speak to more of sort of what the approach as far as, within the context of like PBIS and those types of things. But I think it is about really making sure your approach is in a non-threatening way, right? So if I'm approaching you from behind, I'm going to approach you a little bit differently. Or if I am approaching you from the front, it's going to look differently. I think you really have to to understand that client or that student's triggers as well, or help them understand so that they can communicate it to those who are probably going to be providing that care in those moments of the best way to approach. And then Alex, of course, go ahead and add anything that you would, you feel like focuses on that as well.
Yeah, so I think that's really difficult. So you're seeing that like fawning response, you're seeing that people pleasing, you're seeing that kind of saying all the right things. And then also, like you mentioned, the integration of like treatment's the enemy. And so I think it really starts with the rapport building piece of that, and kind of not allowing the people pleasing answers, not allowing, kind of pushing further than that, but also reinforcing any little bit that you get, any kind of like natural discussion of what's going on, even if we're not even like talking about the full trauma, even if treatment's still the enemy, we want to positively reinforce any engagement that we're getting that is like even a baby step, because that is how we are continuing to like prove to them treatment's not the enemy, like we're going to get through this. But I think that the first thing that comes to my mind with that is truly just time. I think it's going to take a lot of time. I think that a lot of like psychoeducation maybe for the client around some of that. I don't know the age of this child, but if they're older, maybe really kind of talking through some of that. But again, reinforcing the positives whenever you can to hopefully continue to like see more and more of that behavior.
Well, and I think another piece of that, Alex, is to, when those things happen, like you said, rapport building, but also sort of throwing out some of our clinical lens idea of the structure of what that treatment has to look like.
Yes.
We can't get pigeonholed into, we have to do this in X amount of sessions, those types of things, and really utilizing our creativity and thinking outside of the box. So in my experience, I've definitely had clients who were not excited about treatment, or didn't feel like it was needed, or were resistive to that. And so some of those things are getting on their level. Also maybe taking the session outside of the four walls of an office, and getting creative, getting to know what they really like to do. So for instance, I've had clients who were very resistant to that, but they really loved music. And so I really pulled that into the sessions of, let's talk about your favorite songs and let's listen to them and analyze why that's favorite of yours. And then that was able to give me sort of that lens of, oh, okay, this is maybe how I can tie that into the treatment and bring it back, circle it back. I think the other piece is allowing sort of that permission to the client of like, hey, I get that you're not on board with treatment. That's okay. My job is to help build trust so that we can work on what you feel comfortable of, and then continue to build that rapport as well. So I think it's really about like, starting where your client's at, but also getting creative and out of the box thinking of how you can get on that sort of more visceral level of connection. And sometimes that's just sitting near them. And if they're bouncing a ball off the wall, just bouncing a ball off the wall with them too. And I think that's the piece, is in those cases when we have clients who are fawning, I always think of how can I give them opportunities to really control what we do in sessions. So I've even done role plays where I've said, you know what, you be the therapist today, and let's work through it sort of as a counteraction. You be the therapist, you talk about with therapists. That then gives me the assessment of how they view the therapy experience as well.
Absolutely. Suggestion. And I think really like the creativity, like letting that fuel is going to really just, hopefully you got to find something that's going to hook them in there. Sarah Schlegel, your hand's up.
Oh, sorry. No question. Let me lower my hand.
No, you're fine. Great question though. So kind of closing out the conversation of racial socialization and cognitive behavioral therapy framework. So just some of the like things that it suggested that this would help with are to help youth process and cope with racially charged traumatic experiences, to manage additional race-related stress that's going to compound the stress of other traumatic experiences, and then used to really bolster treatment engagement and to provide positive therapeutic outcomes for racial youth, or for racial minority youth. And what we see is that when this is a part of treatment, it has been proven that families are more likely to stay engaged in treatment. And that's a huge, huge, huge protective factor for our kiddos, for our families who are struggling. And it's also important to note that RS or recast theory, this racial socialization theory, has been incorporated into many other treatments. And there are also multiple standalone programs in the United States that are solely utilizing this theory. We just haven't seen it be utilized with trauma-focused or just regular cognitive behavioral therapy. So it's not a new idea to integrate this, but it's somewhere where we really need to extend that research and extend the reach of that more culturally competent lens. So the last kind of thing that I want to talk about related to like cultural factors in treatment is kind of the LGBTQIA experience and what some of the recommendations when working with youth who are of that population are. And so there's some different things for obviously like your practice setting, the system level, the individual level. So when we're talking about our practice settings, we really want to make sure that we have like non-discrimination or discriminatory policies, and we want them publicly posted, provide training if we can on LGBTQ mental health, on that population of people, on what, on how our experience as an LGBTQIA member may differ, or what other struggles that we may experience. From a system level, we really want to review all of our paperwork, all of our intake forms, making sure that like at that level, we are inclusive and that we are asking the right questions in the right language to show that allyship. We also want to improve like resource access. So what that's like gender neutral bathrooms or ability to kind of be safe and comfortable for whatever needs they may have while they're in your like systems setting, whether that's like a clinical practice place or if you kind of have a school or something like that. And then at the individual level, it's really important that a provider like states like and not, like their pronouns. They don't have to disclose all of their identity, but showing that that is welcome, that is something that we can discuss here, that is how I'm going to address you is based on your preferred pronouns, et cetera. We want to make sure that that's part of the first conversation we're having with, if they're of that population, but if we don't know, that should be part of the first conversation we're having with any client that we're working with. And that we want to kind of make sure that if we're going to, maybe therapy takes a turn or a conversation takes a turn to relationships and things like that. And we want to make sure that we're being really inclusive with how we discuss that. It's, you know, I personally am a member of the LGBTQIA community, and I get all the time, like, what does your husband do for a living? I'm like, I don't have a husband. And so just making sure that when we're talking about relationships and things like that, we're being really inclusive. We also want to make sure that we can display LGBTQIA plus safety signals if possible. So flags, signage, other things like that are really, really comforting, especially to youth who are kind of struggling with their identity, trying to figure out how they relate to their sexual orientation or their gender identity, and knowing that their allies around has been proven to be a huge, huge, huge protective factor for that population. When it comes to, and again, we really want to take that minority stress theory approach and understanding that discrimination is ongoing. So that experience is ongoing. We may have to look at those criteria in traumas a little bit different, and we may have to ensure that we are, similarly to the racial socialization concept, providing resources to deal with that ongoing discrimination. When we're talking about cognitive restructuring, it's important that we make sure that we are not, to my point earlier, like restructuring beliefs that are not necessarily untrue. So for example, safety beliefs could be real and we need to like work on appraising that, or a self-linked identity. So you see a lot of, especially like in adults, LGBTQ, but you'll hear things like, it's my fault that this happened because I shouldn't have left the house expressing as a woman, or my trauma is the reason that I like a certain gender or something like that. And so we want to make sure that if those cognitions are coming up in therapy, that we're very, very delicate about how we appraise the validity of them and how we reconstruct them, because we want to make sure we keep validation with real experience. Some other treatment recs that are just kind of interesting that I want to mention really quick here before we hop into our case. Dialectical behavioral skills training, or DBT, which we hear about, is highly recommended for a lot of trauma work and can specifically be really helpful when you're working with an LGBTQIA individual who has PTSD and is like very deeply shame rooted. And so that is where we see more of that kind of like, my trauma, you know, my sexual abuse made me this way, or things like that. When shame is a leading factor, some of those DBT skills can be really, 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 really impactful in PTSD treatment. We also want to look at transdiagnostic cognitive behavioral therapy approaches. This was something that was actually like new to me, so this was a fun thing for me to learn about. But there's an intervention called ESTEAM, which is the effective skills to empower effective men. And it's demonstrated efficacy in reducing minority stress processes that underlies sexual orientation based on HIV disparities. So that's another one that can be really, really helpful if you're working with individuals of that population, or if you're working with maybe a client who has parents of that population, like that can be your caregivers in that population. That can be really helpful to kind of bring some of those things maybe into family therapy or into some more of those conjoint sections and sessions. And then lastly, we have just empowerment and peer supported approaches. There's tons of research proving that peer support is one of the biggest things that we can do for all minorities, is really allowing a space where peers can be the support, where that's the voice that's like that everything is focused on. And so really trying to identify like those youth support groups, PFLAG for caregivers, gay straight alliance clubs in schools, things like that can be really, really beneficial. Any questions, Sarah, before we hop into our case study here?
Yes, I do have one. Thanks for reading
Okay.
my mind. What would be appropriate PTSD treatment modalities and interventions for low support needs autistic individuals, especially when they experience alexithymia? Sorry if I mispronounced that word.
Alexithymia. So that the term alexithymia is not within my therapeutic vocabulary. Sarah Behrens, are you aware of what that is?
So I'm not aware of it either. My experience with working with the autism population is more generalized as opposed to specific. So I don't know that I would feel ethically comfortable sort of giving my 2 cents in on that specific question, but would definitely be able to, find a resource for that person to connect with, to talk through that more effectively.
Yeah, I agree. And the only other thing I was going to mention is I do know that like if a child is struggling with certain levels of processing, we do kind of see that play therapy come out. We can get sometimes more done, but I know that there are some different complicating factors with an autism or IDD diagnosis. And so that's something that I, again, don't feel 100% confident speaking on, but I know that there are resources out there, and I can see if I can try to collect some of those resources and get them over to, I should be able to see who asked that question after the webinar and see if I can provide any information or any kind of links to additional resources for you. Okay, so we are going to hop into study here today. And just to kind of set the scene, we are talking about here at our Camber, Kansas City location in our psychiatric residential treatment facility, which currently is like, I think it serves approximately 36 kids on an average basis. So that's probably roughly the amount of kiddos that were admitted at the same time as this child. They're attending the Camber Academy, which is a school that we have on site at Camber through USD 500. So they are attending school regularly. It's just in a secure environment on site with us. And some of the core program models are positive behavior interventions and supports, UCARU, safety crisis management, and resilience building curriculum. And those are the things that are incorporated into our daily schedules at Camber. It's just kind of like the roots and guts of what we do and how we assist kids. And so this child is going to be exposed to all of those program models through our daily programming. Now let Sarah take it away.
All right, so for the purposes of this case study, the client that I'm going to be referring to, we're going to call her Katie. Her diagnosis was PTSD and ADHD as well. At the time of treatment, Katie was around 15 years old. She also identified as female. Her race is Caucasian. So she was currently living in an adopted parent situation where she had a mother and a father, 2 siblings. They were also adopted as well, but her biological siblings were adopted by a different family, and they did not have open contact with Katie. Cultural considerations: she's from a very small Kansas town, and so very much in the Midwest sort of mindset was very strong there. There was some stigmatization around getting mental health treatment and some of those things that we had to address and like talk throughout the case. And so mental health was, something that was a lot of pre-teaching around, like, what does that look like? Really exploring how that can be a part of the health, right? Because so many times they think of it as separate items. Some of Katie's strengths was, she was very artistic. She could be very assertive in a good way. She liked to be helpful. And she could be really insightful in the right environments. And we got to see a journey through the therapy process. The clinician was able to really see that insight grow from her standpoint, and as well from the adoptive parent standpoint as well. So moving on to the case summary. So Katie was initially referred to residential care due to ongoing suicidal ideations. She had also had some attempts. She had a history of aggression, self-harming behaviors that included scratching and some of those things on her wrists. And so she was initially referred to us for that. So when Katie was accepted into the residential program, we also kind of knew her already because we had already had her on our acute hospital. And so she had had multiple hospitalizations in the previous months leading up to her residential care, not just at Camber, but other places as well. She was also getting a lot of treatment in the community mental health setting as well. She also had some support in her school at her home-based community. So when she first arrived at Camber for treatment, she really appeared to be guarded. She was sort of one of those kiddos who kind of, was easing in, sort of tiptoeing onto the unit, so to speak, being observed, just really observing the unit, being curious in some ways about the folks who were providing care, her therapist, medication providers, those types of things as well. We would see some other behaviors such as minimizing her responses, displayed a lot of avoidance towards treatment. So we talked a little bit earlier about, treatment avoidance in one of the questions, and she definitely was somebody who was, actively engaged in that. She was very non-voluntary, so to speak. She had experienced a lot of toxic stress situations in her recent history leading up to her admission. Some of those things were including, just having, you can go to the next slide, Alex, too. So some more recent ones were that she had experienced a recent death of a family member. So that was really high on the list. It was her grandmother who was very close to her, even though she, wasn't living with her currently. She had been in multiple foster placements. So once she had been removed from the home. And so that was a more emergent, sort of complex trauma that she had been experiencing leading up to. But just going back a little bit in her case history, throughout her entire life, some of the information we were provided and that the adoptive parents were luckily able to obtain, that she had a lot of family history of mental illness. PTSD was something that was prevalent in the family, as well as some other diagnoses. Her family members, she had had parents who were incarcerated due to their substance use, as well as the history of substance use across, a lot of different continuums. So not just alcohol abuse, but some drug abuse as well. And one of the things that isn't necessarily mentioned here because we didn't have a lot of historical information on it, but there was some indications that there were a lot of different people coming in and out of the home. So that instability of your home environment prior to her being removed from the home. Around the age of 5, she did witness that domestic violence between her biological parents. And so she not only witnessed it, but also would hear it, which also created, the right environment to create some PTSD as well. She also witnessed the biological parents' drug use. And then she was then removed from the home after a critical event that included one of her parents being arrested for drug possession and intent to sell. And then, of course, like I talked about, some of that inconsistency in the foster homes. She did experience some sexual abuse in a foster home, the loss of her grandmother, multiple foster placements, which I just want to highlight because I think sometimes people don't always remember or think to include that in the trauma history. And so that exposure to when you already feel unsafe with folks who are supposed to keep you safe, and then continuing on that journey of I'm in this home for this night or for this limited, time. And as well as we saw that, then in the hospital setting too, because there are staff members who are coming in and out. Every shift has different people. And so that would be a trigger for her as well, is just the different faces that she saw combined with her trauma history. And so finally, at the age of 14, she had found a foster home that was a good fit for her, and long-term wanted to be where she belonged and become her forever family. So they did adopt her. But obviously, I think it's important to note that, trauma still comes out after those things. And so love counts and is really great for that, but there's still some treatment work that needs to be done. So moving on to some of her symptoms that she reported initially were some depressed mood, uncontrollable worry, poor self-esteem, intrusive thoughts. She experienced a lot of misplaced rage and aggression, especially towards, those new caregivers or those parents, as well as grief over the death of her grandmother, grief over losing her bio family connections, not having her siblings, not having her biological parents in her life as well. She would have a lot of flashbacks of the domestic violence that occurred, hypervigilance, irritability. She would also engage in elopement behaviors, and she had difficulty concentrating, increased appetite, which was leading to some overeating. And she was hyper attuned, and she had a heightened startle response. So she is somebody who didn't like loud noises, couldn't stand for anybody to approach her from the back. And so that was all stuff that we had to take into consideration in her treatment. So she had complaints of perceived victimization. So that's important to know that it's her perception, right? So it doesn't matter if I witnessed the interaction that she's talking about. It's her it's the way she perceived that interaction was important.
We're not talking necessarily about the trauma she did experience. That is more related to experiences
Correct.
that she is reporting as traumatic, even though, or victimizing.
Right. So for example, she perceived that another client was going to, touch her on the shoulder. And so she had a response to that, right? Like she was very triggered by that, when really the client was just kind of going to the next area. And so it wasn't that, but in her mind, that client was sort of coming at her in an aggressive way. Interpersonal peer relationships. So that obviously plays into that piece. The depression, experience a lot of uncontrollable thoughts of wanting to die or preoccupation with dying. Irritability, anger, triggered by males, especially because some of that sexual abuse trauma. Any unexpected touch, like I talked about. She initially had some limited insight, but as I said, her strengths were that she did have insight, flight of ideas, and some impaired judgment. So some of the approaches that were utilized, in the next slide, we'll go over specifically by those who were treating her. So back one, sorry.
Sorry, no, my computer, wait, hold on. Sorry, let me go back. I apologize. We froze and then here we are.
Okay. So essentially, really starting at assessment, right? We need to gather the facts. We need to gather the facts from collateral information. We need to gather the facts from client report, their historical, knowledge of these situations, as well as our observations and some of those other people who maybe have been involved in her life. So her school counselor was, imperative, and some of those other supports, her outpatient therapist. One of the assessments completed is the UCLA PTSD Reaction Index score, which her original score was a 68, which is considered, as we learned in the last training, that that's really high. So the scores range from 0 to 155. Anything higher than 31 though indicates the possible diagnosis of PTSD. So she was at a 68. The approach that was really utilized with her from a therapeutic standpoint was the trauma-focused CBT or TFCBT, and then really integrating expressive therapies. Specifically to Katie, she really loved art. And so that was utilized in so many different ways for support and for her to process some of those things. And then, of course, the element of medication management. So through this process, there was some sort of adjusting of different medications. They did have to reassess if the medications were really effective for her. And sort of where we landed on that combination that worked best for her towards the end of her stay was being on Abilify, Intuniv, and Lexapro. So the clinical interventions, just to kind of go through what that looked like a little bit more. In the individual sessions, we did focus on, the trauma-focused CBT. There was also family therapy that the therapist included the adoptive family members on. They did a lot of psychoeducation, a lot of parenting skills. I will note that with family therapy of adoptive parents, it can get, in Katie's case, it was very interesting with her due to some of those factors of that sort of processing through some of that misplaced experiences or thoughts or feelings, cognitions around bio parents that were then projected on some of those adoptive parents. So that did, play out in those family sessions, and creating skills on how to sort of name that and then be able to process through and safely move on from some of those cognitions. And then, of course, group therapy was really focused on advocacy. How can Katie, how can we build skills so that Katie can self-advocate, as well as, helping her to understand that her needs are important and she has the ability and should be speaking towards those needs. Self-esteem, emotion identification was a key as well, because, Katie could engage in some numbing and didn't want to express her feelings, nor could she connect feelings with what she felt in her body. And then, of course, regulation, emotional and behavioral regulation. And so just really quick, some of those symptoms that are addressed in, just for a refresher for the trauma-focused CBT, were cognitive problems, relationship problems, affective problems, family problems, traumatic behavior problems, and somatic problems. So before we go into that piece, just to give a little focus on some of the techniques. So I'm going to kind of read off some of the paperwork that we utilize just really briefly to talk a little bit about how you connect it, right? So part of that cognitive processing. So how did I get here? How did I get to the place where I'm feeling right now? So she was able to identify that people hurt her. The bio family aspects that were hurting. There was too much pain. Just feeling like nobody would interact with me or teach me how to focus on the problem and then create steps to manage the problem. So some of the things that she was identifying as, how does this affect me now, is I avoid people who I feel like might hurt me. I reject people before they can reject me. I might minimize and avoid talking about those uncomfortable situations. I have a lot of conflict in my relationships as well. So that's kind of some of that information on how that played out. And then the next focus then was on, how do I stay safe when these cognitions come up for me, or when I'm triggered by different situations. And so if you can go ahead and go on to the next one, where we can talk about what we did for her environment, because that is also key, is being able to create an environment, or like I said before, that system of care, right? So for our specific setting, our direct care employees, really creative is in a sporting environment where they were building connections of, I'm a safe adult for you to walk alongside. And so I'm not here as necessarily your authority figure, but I'm here to help guide you and create a safe space for that. Having a lot of positive interactions. And so for Katie, it was really important that our staff seek her out to provide those positive interactions, as opposed to putting it on her plate of try to engage in positive interactions. Having nurturing and positive relationships, quality time. And so with direct care, it was really being able to nurture those relationships and, hey, grab her for a game of Uno. If she's having a great day, she really liked to have one-on-one time with staff, where maybe they were doing some co-drawing on a picture, some of those types of activities that show nurturing. In the family therapy sessions, there were some nurturing activities that were completed to really regulate and co-regulate together in those sessions. Direct care also helped support her individual needs. So, she's being able to talk about her triggers, process those triggers when that happens, talk through when there was a big behavior or a really big emotion that she was experiencing, on how to, name it, how are we going to process through it, and then doing sort of a moment by moment of what led up to this, what happened, what can we do differently? So reinforcing some of those techniques being used in the therapy sessions, and then really being consistent and making sure you're following through. It's that shared accountability piece. And I know we're kind of getting short on time, so this may be a little bit quickly, but support plan, making sure that we're hitting all those marks, right? So the things that you're doing in therapy are being practiced on the environment that you're in, whether that for us was the residential, unit, or if you're at home. So making sure you have the appropriate emotional regulation skills that resonate with that particular client. So for Katie, it was deep breathing or taking a breath, doing progressive muscle relaxation, naming your triggers and being able to have that discussion with those who are your caregivers. So not just your family members, making sure your school support staff know that, making sure that your friends know those triggers, making sure that you can identify some of those triggers in your own body. Some of the interventions then too are, allowing her to take a break so that she can process, because that was something that she needed time to do. If things were overwhelming, wearing noise canceling headphones to kind of minimize the noise behind it, right? Provide her with options to do something. So, Katie, it's group time. So that pre-teaching of that transition, but also, can you find a seat on the couch or at the table, sort of inviting her into that space of the therapeutic healing process. And then of course, those positive reinforcements of the stars. So a token system, catching them being good, so to speak, or catching them using those techniques that they're working so hard to learn and engage in. So prior to discharge, Katie was able to identify that she was experiencing improved sleep, focus, attention, her self-esteem went up, her awareness, insight, sense of self, motivation for the future all increased. Her PTSD RI score at the end of treatment was at 40. So obviously she still had some work to do, but it was at a level where we knew that she was able to do so in a lesser restrictive environment. And that is ultimately what we want to happen in a residential setting. And then of course, discharge planning. We start talking about discharge planning from the first meeting on, because we want to make sure that we're setting them up for success. So we collaborated with those folks who are very integral in her life, her guardians, her insurance company, the mental health center, the school social worker who was a great support to her. And then some of those recommendations is to make sure the setting that she's in provides a structure and supervision to address her emotional and behavioral issues, because she still needed a lot of support. Continue with the individual, the family, and the group sessions to focus on the reasons for admission. So especially with some of those other things, such as the suicidal ideation and how that then triggers some of those PTSD symptoms as well, and how do we manage that outside. And then of course, making sure that she had the services she needed, including, her individual and family therapy, but then the case management aspect, as well as continued medication services to ensure that she had the support needed to continue on the journey of her healing.
Yeah, and I think an important point to note is that really is that evaluation of least restrictive care. Like to your point, this child needed a lot of care post-discharge with us, but at that point it was determined that they should be in a less restrictive setting, and that we know that least restrictive settings are always going to be paramount to treatment as long as they can maintain safety. That is the conclusion of our presentation today, and we will be emailing out the slides later, but I didn't know if we had any final questions, Sarah Schlegel. If not, if you guys need to hop off, feel free to do so. If you want to stick around and ask some questions, I'll be here for a few minutes with Sarah Behrens.
We did just have a lingering question about if I filled everything out the past webinar, but didn't see the certificate, how do I go about receiving it? I know that you addressed at the beginning, but might want to review it real fast.
Yeah, just go ahead and shoot me an email and I'll get that over to you. Sarah, do you mind putting my email in the chat or in the Q&A?
Sure.
Thank you. Awesome. Okay. Well, we appreciate everyone's attendance today. I am going to leave this webinar open for a little bit longer because apparently that was an issue with the survey last week. But thank you for your attendance, and we always appreciate everyone being here with us and engaging with us to really, bolster the mental health community supports that we have here.